Okay, as people start joining in, gonna give it a couple of minutes so we get more participants on the audience. Okay, it's 8:01. So good evening, everyone. Thanks for joining the February 2023 CIS case webinar series. It is a pleasure to have you tonight. My name is Hanadis Ale. My friends call me Hani, and we are all friends here at the CIS, so please call me Hani too. I am an allergist and immunologist at Joe DiMaggio Children's Hospital in Florida, and I am a member of the Early Career Immunologist Committee at the CIS, which sponsors these webinars. I am moderating tonight's first case, and I am very excited because tonight we have very interesting cases and amazing senior mentors. But before we dive into our first case, I would like to remind everyone that training membership for the CIS is free, and you can apply by going to the CIS website, www.cleanimmsoc.org. And as well, I wanted to remind everyone that our webinars are intended to be interactive. So please place all your comments and questions in the chat box, and I will be monitoring and filtering them for the presenters for our presenter for the first case and for the senior mentors. So our presenter for tonight's first case is Dr. Gail Boodoo. She is a senior pediatric resident at Joe DiMaggio Children's Hospital. She's also my mentee, and she worked with me and was very involved in this case, and she will be presenting a CG dilemma. Our senior mentor is Dr. Stephen Holland, and Steve doesn't really require an introduction to this audience, but as a short introduction, he's the director of the Division of Intramural Research at the National Institute of Allergy and Infectious Diseases of the NIH. And supporting us also as a senior mentor is Dr. Douglas Kuntz. He is a senior principal scientist, head of the Neutrophil Monitoring Lab and Immunological Monitoring Lab of the Frederick National Laboratory. Thank you both for joining us tonight. And before further ado, Gail, please take it away.
Alrighty, thank you, Dr. Hani. And thanks everybody for joining us tonight. So I'll just jump into our case at CGD Lima. Okay, so our patient is a 4-year-old male. He was born in the Middle East. He was here in the United States with his mother, who was pursuing a tertiary degree. So while he was out with his mother, he was at the store and he fell. And he sustained a laceration to the left cheek and chin 2 weeks prior to hospital presentation. So he sustained the injury, and mom just, she said it was not very serious. So she tried to care for it at home. She cleaned the area. She applied topical antibiotic cream, and she just monitored the site at home. However, within 4 to 5 days of the incident, the area became red and there was a yellow discharge as well. So she took him immediately to the urgent care where they prescribed clindamycin orally and they discharged him home. So after 4 days of clindamycin, his mom noted that the area was still quite red. There was a scab forming. It looked really angry to her. So she took him now to the emergency room. There were some concerns for an abscess. So they did a screening CBC and CRP, which were unremarkable. They also did an ultrasound, which only revealed soft tissue edema, but no drainable fluid. As such, he was discharged home to continue clindamycin as prescribed. However, they gave him advice to return to the hospital should it become worse in appearance or if he had any pain or any fever associated. So our patient actually returned within 48 hours. And at the time he did have pain, swelling, worsening erythema, and he had a fever, which was reproducible at our institution at 38 degrees Celsius. They did a CBC and a CRP, which remained unremarkable. And the ESR, however, was elevated. And you can see here in the image, Mom had said that there was generally a rim of redness around the actual original site, but now at the second presentation, the site had actually increased in terms of its actual margins. So in light of this failed outpatient management, the patient was admitted to hospital for further care. At the time, he was managed as a cellulitis with an abscess. They decided to keep clindamycin, but give him as an IV preparation and apply warm compresses to the area as well. Despite these interventions, he actually had no clinical improvement. So we were a bit concerned. So at this time, we were entertaining immunodeficiency. So we probed a bit further into his history, and it revealed that the parents were first cousins, but further, he had actually been admitted to hospital in the United States 2 years prior, sometime around when he was about 2 years of age, after he had sustained a similar injury, but this time on his right lower limb. It had not healed either, so he had been admitted to hospital. He received antibiotics, and he had debridement as well as some amount of grafting as well. So he actually, and the biopsy that they had from that test was positive for rhizopus. They had to treat him with antifungals, and the team managing at the time had concerns for CGD. His DHR was also abnormal. However, the patient returned to the Middle East after he was discharged, where medical workup was actually not pursued. So with this history in mind and his current presentation, we decided to consult our immunology team, where they did some workup. It revealed elevated IgG and IgA in the setting of normal IgE and IgM. His lymphocyte subset panel also showed normal T, B, and NK cell counts. Lymphocyte subset panel, mitogen and antigen proliferation studies were also normal. His strep pneumococcal antibody showed at least 50% protection, which was appropriate for his age. He had also protective tetanus and diphtheria titers. His cytokine panel had elevated inflammatory interleukins and high IL-6 signature, which was in keeping with his acute infection that was ongoing. He had a normal G6PD assay as well, and notably, he had an abnormal DHR. So here we see the DHR results, and it showed neutrophil oxidative burst with a broad peak of intermediate granulocyte DHR fluorescence without a normal population. And that was actually his initial study, which we repeated again, and it had very similar results. So at this time, we would love to ask the audience about their thoughts with regards to differentials.
Okay, so Amit put CGD with P47 defect and FC1 gene, autosomal recessive form of CGD. Very nice thoughts. Thank you for this ARCED. So everybody's on the same page about ARCED. There is a question about which methods do you use for IL-6 and interferon gamma signature. So the method that we use is the cytokine panel that is sent out to Cincinnati Children's Hospitals. That's how we got those results. Short broad peak DHR is suggestive of P47 defect. Okay, other than CGD, guys, because any other thoughts? I know it's a dilemma. So it's a dilemma. That's if we were so sure of the CED, we wouldn't have had that dilemma. But I love the thoughts, are very good. Anything else? LAD, very good. MPO deficiency, I love it. MPO deficiency, very good, very good. It's something else that can give you an abnormal DHR. Severe G6PD deficiency, excellent, that also give you an abnormal DHR. MHC class 2, RAC2. I love Jenny's thoughts about RAC2. Very, very good. Anything else? I love the differentials. And yes, CGD was the top all the time, the crown of the diagnosis, but we thought about all the things because the CGD was not showing up as such as much. Yes, very severe G6PD deficiency give you the same presentation, RAC2. Okay, so let's continue.
All right, so the great reveal, of course, we were thinking CGD like everybody else, but I think you guys touched on pretty much all of our differentials, RAC2 deficiency, MPO deficiency. We also had the Mendelian susceptibility to mycobacterial disease, the MSD-MD, as well as really severe forms, like you said, of G6PD, which could actually mimic a mild type of CGD as well. That was excellent. Okay, so we actually pursued genetic workup for our patient as well. GeneDx CGD panel showed no variant in known CGD genes. In Vitae panel revealed a pathogenic variant in the MEFV, which is associated with autosomal recessive familial Mediterranean fever. However, this didn't really fit the phenotype of our patient. There were also multiple variants of unknown significance in several genes. However, once again, the patient's phenotype didn't really fit with these variants. We also had SNP microarray, which revealed long contiguous series of homozygosity in multiple chromosomes, as well as some genes that were duplicated, particularly the four mentioned on the slide. However, we thought these were benign variants, and the long regions were likely in keeping with the fact that his parents were related. So in summary for this slide, our genetic workup didn't really get us very far at this point. So despite those, his genetics kind of not really agreeing with our thoughts, we still were pretty adamant or convinced he had CGD. So just very briefly, it is a disorder characterized by phagocytic cells and their inability to generate superoxide and its toxic oxygen derivatives, which are essential for microbicidal activity. Patients have deficient or absent superoxide, and they're susceptible to recurrent infections, bacterial and fungal. So they particularly lack one or more components of the NADPH oxidase complex, which is more important for this chopper right now. So this multi-component enzyme consists of at least 5 subunits, 2 which are membrane bound, and you see it here on the image. And it's our GP91 and our P22. And then we have 3 that are cytosolic, which is P40, P47, and P67. But newer data actually speaks of and describes a 6th component known as which is a chaperone protein called EROS, which has been found to be key for GP91 and P22 heterodimer expression. So this is a new one. You can see it there kind of just associating with both entities itself. So the respiratory burst oxidase is usually dormant in a resting cell. However, upon activation, when you have an infection, they usually start moving. So the cytosolic proteins, those are movers. That's our P40, our P47, our P67. They are the guys that translocate. They go to the membrane where they're associated with the membrane-bound protein subunits, which is our GP91 and our P22 components. So in rare cases, dysfunctional activity of one or of these components is significantly decreased. Hence, we end up with the CGD phenotype. So I thought this is a pretty nice slide here, which kind of shows you our subunits there on the left, as well as the genes that they're associated with. We see that mutations involving the GP91 occurs more frequently and follows more of an X-linked pattern of inheritance. However, I wanted to emphasize the P47 mutation that's on the NCF1 gene, which is actually responsible for most of the autosomal recessive CGD. And this will be important to remember later when we are discussing our patients. So small spoiler alert. I also wanted to mention the 6th subunit, which is the EROS at the bottom there, which acts as a chaperone protein. Like I said, it is responsible for a new and rarer form of CGD, which presents as a loss of bursts, respiratory bursts, and GP91 expression in the phagocytes. So going back to our little patient, our 4-year-old, he was admitted and he remained in hospital actually for several weeks undergoing treatment while we were concurrently pursuing a more definitive diagnosis. So while admitted, his antibiotics were actually switched multiple times, and he also had debridement multiple times, and he had a biopsy done, which was positive for rhizopus. which, as you will remember, he did have 2 years prior. So we actually even tried to increase therapy by sending him for hyperbaric oxygen treatments and repeat rounds of debridement. So you'll see here on the first image on the upper left-hand side of the screen, that was how his lesion appeared when he initially came in. The second one on the bottom, it was a few days after with our clindamycin ongoing. The two images on the right were after 2 rounds of debridement. So we continued to pursue our diagnosis despite initial testing that was inconclusive. We did whole genome sequencing, and that was negative. So we consulted our friends at the NIH for further advice, Dr. Holland and Dr. Kuntz. And we started with the protein detection with Western blot. And it showed that we had no P47 expression. Right there, it's missing. So this was highly suggestive of CGD, and it was sort of reassuring to us that we were going in the right direction. So as you may recall from the previous slides, it is a P47 that is associated with the autosomal recessive type of CGD. So I just wanted to speak briefly about the NCF1 gene, which is long words neutrophil cytosolic factor 1. So about 25% of patients with CGD have mutations in that particular gene, which encodes the P47. It is a structural component of the actual respiratory oxidase, and it's a very it's a common mutation in the autosomal recessive form. So a very common mutation that is found in these patients is a GT deletion in the GT-GT repeat sequence at the beginning of exon 2 of the NCF1 gene. So we remove the GT, and this whole thing just causes a whole frame shift, which creates a premature stop codon, which then truncates our protein, which, as you can remember, as you can imagine, would cause some problems. So this GT sequence is due to recombination events with 2 NCF1 pseudogenes, which are there flanking our regular NCF1 gene. And because of this whole interaction, and they're so similar and so close, it could actually lead to a lot of issues when trying to detect it with our usual studies. So back to our patient, we're still trying to figure him out. So our friends at the NIH, they suggested as well our droplet digital polymerase reaction, which we thought would be helpful in particular because with this type of study, it uses PCR with 2 distinct probes, which recognize either that wild type p-sculpta, which is a GT sequence, and it also recognizes the delta GT sequence, which is our pseudogene. And it is very helpful in determining carrier status of relatives. So with this in mind, we were able to check the patient, his father, and his mother to see what their status would be. And they actually had appropriate ratios respectively. They had the expected 2 GT on the 6 copies of the actual gene and pseudogene, which suggested to us that the mutation for our patient laid specifically outside of the actual expected region, be it intronic or exonic. So ultimately, what this kind of indicated to us was that Sanger sequencing is not always sufficient to identify the defects that we are looking for, particularly because the amplicons, including the NCF1 and the pseudogenes, are both in the mix, and it all just complicates the entire read. So in approximately 20% of cases, commercial genetic testing miss P47 CGD patients when the mutations are outside of the NCF1 region. So you might have a patient that looks like CGD, and the testing, like in our case, is not really too strong for a confirmative diagnosis. So Western blot in these cases is critical for P47 CGD diagnosis, as well as our droplet digital polymerase can also produce helpful ratios, especially when multiple of our genetic studies are coming back normal. So what was our patient's final diagnosis? It was of P47 Fox CGD, like most of you said. This NCF mutation occurred due to a single nucleotide change at position 579, which coded for a stop codon that prematurely truncated the protein. That particular nucleotide change was distinct in our patient and actually not found in the wild type. And that typical delta GT mutation, which is expected in CGD, was not found in our patient. So our learning point from this was that one tool is not sufficient for definitive diagnosis. We persisted despite this elusive diagnosis, especially since clinically the patient did fit some sort of immunodeficiency, particularly CGD. It took more than 2 abnormal DHRs, if we're counting the one that he had done when he was first admitted, absent P47 on Western blot, and now confirmatory genetics to make this affirmative diagnosis despite our preliminary negative testing. So I guess the next learning point is to persist. So right back to our patients. So we actually did share with our patients' parents the Western blot results when we had them, even though like the genetics was still pending, just because everything was kind of coming together. However, they did not accept the diagnosis of CGD. Further, they were not open to interferon gamma as a treatment modality. Unfortunately, our patient never achieved clear margins despite aggressive use of antibiotics and antifungals and several rounds of debridement. He was ultimately discharged after his parents conveyed their desire to go back to the Middle East. Ideally, the 3 arms of management that we would have liked to offer this patient was to actually gain some control of his infection, which, like I said, we never really achieved clear margins. We would have liked to send him home on antibiotic and antifungal prophylaxis, but query if he actually did receive that treatment when we discharged him. And ultimately, we would have wanted to offer him interferon gamma prophylaxis. However, he did return home to the Middle East, hopefully to receive some more care. So that is our case. I think I will hand it back over to Dr. Ale. Thank you so much for listening.
Thank you, Gail. That was great. I just want to mention really quick before I let our senior mentors to timing is that I did have a very serious conversation with mom and dad, and with an interpreter and everything, and I explained all our results, even though our genetics were still not complete, that or everything pointed to the diagnosis of P47 CED, and unfortunately they were not accepting that diagnosis. One of our colleagues, Dr. Ackard, and she knows 2 immunologists in his home country, and they were trying to help for these doctors to see the patient, but they never seek care. And we were very sad about that because we really don't know, and we tried to reach out our social workers. We really don't know how he's doing, and obviously it's a little concerning. Okay, so I leave it open for Steve and Doug.
Are you going to show the next slide there, honey? I think it'd be.
Gail, you have the presentation. There you go, that one.
I think it'd be great if Doug could walk us through that, because this is really Doug gets all the credit for all this work, and there's just nobody who understands P47 better than Doug Kunz.
Thank you, Steve. So we were actually took a chance basically, and we sent it out for P47 Sanger sequencing with the hope that we might see something. We realized the limitation of Sanger sequencing because you're always going to sequence the pseudogene and the wild type gene. But as we were looking through the histograms, we actually picked up a what appears to be heterozygous, but it's heterozygous because of the pseudogenes. We saw a mutation at position, whatever it is, 579, a G to an A, and what that is a previously reported mutation in P47. So, you know, although that's not absolutely confirmatory because we don't know if that mutation is on the wild type. It's very likely that that is where the mutation is, especially given the lack of P47 in the Western blot. I did see one comment about doing flow for the NADPH oxidase components, and we actually did that as well. And we showed that they didn't have P47 by flow as well, and they did have all the other components. So we take that in consideration with the ddPCR, and what the ddPCR basically was telling us is that they had a mutation somewhere else than the delta GT. And so because all the parents and the child all gave in essence a 0.33 ratio, which basically indicates 2 out of 6. And so they had 2 GTs out of 6 total GT plus delta GT. And so with that kind of ratio, we know that they have the GT at the start of exon 2, or they most likely have it. And so that kind of indicated that the mutation was elsewhere in the P47 gene. So everything kind of fit together. It still would be nice to have a way to actually get specific sequencing done, but that so far we don't have that capability yet.
Well, but Doug, so I'm still confused about this, and I hope that Gail and Hani, you have reached back to GeneDx to tell them, to show them the data, because it's simply not the case that they don't have it. And I think, as Doug points out, everybody's nervous about these sorts of things, but you had really everything you need. There was no question in your mind, nor in mine, that this
Right.
kid had CGD. You had an abnormal DHR and a fungal infection that was recurrent. That's a slam dunk. And none of those other things in the differential. There's not an MSMD that does this. There's not an MPO that does this. Nobody else gives you invasive rhizopus, even though that's an uncommon infection in CGD. An abnormal DHR with invasive fungus in a kid from that kind of family structure, there's just not anything else in your differential. So you did exactly right, which was to press for it. But GeneDx, I'm sure they have these data. And what they are worried about, and is often the case, they're worried about the problem of a pseudogene. And just like Doug said, how do they know that it's not in there? But I suspect if you called them up and said, actually, I have an abnormal DHR and I have an abnormal Western blot, and I know that there's got to be a protein truncating mutation in P47, do you have anything on the analysis, if you did a whole genome, do you have anything there that looks like it? They could go back and find this. Same thing applies for Nemo. There's no reason that it can't be identified. It just raises all sorts of anxieties for people who are worried about the legalities of their reporting, about telling you something that they can't absolutely confirm is in the gene of interest, could be in a pseudogene. But it's, I think, a really important point that P47 and Nemo are 2 of the genes that you as an immunologist and an infectious disease person really care about, and you will never get those back without dedicated studies.
So one of the comments on our chat is that GeneDx CGD panel is so far the only commercial one that offers to perform capillary sequencing detection of exon 2BC of the shortened NGS mapping issue. So we'll pick up common delta GT and other exon 2 variants, but won't guarantee pickup of other MCF variants affecting other exons. And they said, I have asked about the 124C2T and others variants, and they won't even try it. And Blueprint excludes 5 of the exons from analysis.
Yeah, I mean, these are companies that are, it's not like they're trying to do a bad job. They're not trying to keep data from you. They're responding to the fact that there are parts of sequencing that are just plain hard. But you have to, and I think realizing when you have to press for a multimodality approach and then pursuing it is really important. I don't think there is a commercial Western blot out there, and nobody does Western like Doug does Western, I'm telling you. And I don't know about the flow. I'm not sure. There are many places that do flow for components. I don't know if it's commercially available. and somebody else might know that it might be available in Denver. I'm not sure. The question about Nanopore is a really interesting one. It could be these long reads might let you figure out what's there, but I don't think anybody's doing Nanopore for diagnostic purposes because the accuracy is relatively low. They're great for research. I don't know if anybody's reporting those without going back to a Sanger if they get a hit. And I don't know, Sahar, if you know about that.
So Nanopore has improved their accuracy because now they do it they don't call it bidirectional, but it's reading off both strands. But PacBio is the other long read technology, and it has good accuracy at this point.
Is that being used in commercial CLIA certified labs?
Not that I'm aware of, no.
I think Illumina has a new technology that is going to be released sometime this summer where they're getting long reads as well, but I'm not sure, they have put out some literature that they are able to distinguish this NCF1 from the pseudogenes, but I don't know what status they are yet.
Yeah,
Okay.
Ninesh says, I think Ninesh's point is really important. Regardless of the sequence, you knew enough, actually at the initial presentation, if the family had been interested, to say this kid really needs a transplant. An invasive fungal infection with an abnormal DHR, 20 years ago, you wouldn't have thought twice about this. The one question I had, Gail, is he had the same organism show up twice in 2 different body parts. Did you look at all to see whether he had it anyplace else? Rhizopus is an unusual infection in CGD. And in general, CGD patients don't harbor the same organism for a long time. But if they do, that often means that it's hanging out somewhere. And I wonder if you did a skeletal survey or, CT scan of the rest of him to see whether it might have been someplace.
Yeah, so we actually did that was a very thoughtful consideration because we also work with our infectious disease colleagues as well. And that was 100% the thought process. So we did look and we weren't able to find anything.
That was another puzzling thing for us. It's the organism. And
Yeah.
we were discussing that in our emails, Steve, if you remember that we were kind of thinking what this could be other than the CGD that was not showing, and we had other colleagues kind of giving ideas, and we are very grateful for your help and for Doug that was persistent and found what was wrong. So the only sad part of this case, I would say, is the family not accepting the diagnosis of the patient, and unfortunately going back and not allowing to receive help from even the immunologists that are over there. But our social worker will continue to try to see if there is something that can be done. Thank you, everybody. And thank you, Gail. Great job.
Thank you, everybody.
Yes, thanks, Gail, Hani, Doug, and Steve. Now for something quite different. I have Cody Nelson that I have the pleasure of introducing, who is one of our first-year allergy immunology fellows at Brigham and Women's. And we also have another fantastic senior moderator joining us today. We have Kate Sullivan here, who, again, like our other senior moderators, really needs no introduction, but nonetheless, Kate is the Chief of Allergy and Immunology at Children's Hospital of Philadelphia. She is a leader in the field with over 300 publications in the PIDD space. And I'm going to make a career out of introducing Kate professionally. And with that, Cody, I'm going to allow you to take it over.
Hi, everyone. We don't have quite as catchy a title, but maybe Gail can help give us some help with that. So going right into the case, a patient initially presented in October 2005 was diagnosed at the age of 14 with lupus and primarily renal manifestations. At the time of presentation, his creatinine was in the 2 to 3 range, and it increased to a peak of around 5. The phenotyping of his lupus, his ANA was 1 to 80, double-stranded DNA 1 to 40. He had a positive anti-Smith antibody and undetectable complement levels. He was diagnosed on kidney biopsy with class 4 glomerulonephritis and treated with pulse dose steroids, and then maintained on prednisone and Cellcept. A couple months later, he was diagnosed with a case of GBS meningitis and had an IgG level that was obtained during that hospitalization, which was noted to be 150 milligrams per deciliter. And interestingly, his IgG level had normalized about a year after this episode of meningitis. So he did well for about 5 years, was transitioned to Plaquenil monotherapy in 2010, and then for a decade had no signs of active lupus, but did have worsening renal function, and was noted to have a positive antiphospholipid antibody, but no history of hypercoagulability. In September of 2019, he received kidney transplantation from a living unrelated donor, and received quite a number of immune modulatory agents during preceding his transplant and then following his transplant in the setting of acute rejection. So he received alemtuzumab, rituximab, eculizumab, basiliximab, belatacept, high-dose steroids, IVIG, and plasma exchange. And the documentation at the time that the allergy immunology team got involved was a little sparse. And so the number of doses, the timing and the number of doses of medication was challenging to reconstruct. He had a number of complications. Initially was diagnosed with a renal artery thrombosis that was attributed to his APLS. Also had this recurrent perigraft abscess that lasted the better part of a year with ESBL E. coli and subsequent bacteremia. He had CMV viremia. He developed acute rejection, both antibody and T-cell mediated, hydronephrosis, had stage 5 CKD following his transplant, and also had this confusing episode of possible aplastic anemia that seemed to correspond with starting a cephalosporin. So a year out from his transplant in October 2020, he was hospitalized for a bone marrow biopsy and persistent leukopenia. And at that time, the Allergy and Immunology Consult Service was engaged, and the question was whether immunoglobulin replacement was indicated. And his initial labs during that hospitalization, his IgG level was 395. His IgA and IgM levels were within normal limits. He was noted to be anemic and leukopenic. His absolute neutrophil count was 1,300 and absolute lymphocyte count 110. His bone marrow biopsy during that admission showed hypocellular marrow with erythroid predominant maturing trilineage hematopoiesis. Again, to recap his infection history, he had this GBS meningitis that occurred around the time of his lupus diagnosis. He had this persistent perigraft abscess following his transplant with ESBL E. coli, CMV viremia, diagnosis of incidental lung granulomas in 2019 around the time of his transplant, but no history of pneumonia, no history of sinus infections, ear infections. His medications that he was on, 5 milligrams of prednisone daily, Cellcept, letermovir prophylaxis, amlodipine, labetalol, erythropoietin, eltrombopag, warfarin, sevelamer, and sodium bicarbonate. He was noted to have an allergy to statins and intolerance with myalgias. And his family history was significant for a maternal grandmother with rheumatoid arthritis, and his sister was diagnosed with cutaneous lupus, but no atopic or immune deficiency history. So I'll pause for a minute with any comments on the thoughts of his hypogammaglobulinemia and whether what the need is for further evaluation.
While people are getting their thoughts together to put things in the chat, I also want to welcome Laura Bankova and Anna Helena Johnson, who are part of this patient's care team. And we certainly encourage you to participate in the chat as well, because you all know this patient very, very well. And it looks like there's some thought that perhaps he should have a repeat flow cytometry. And then a question, is this all just a post-rituximab phenomenon and nothing else? And maybe we don't need to worry any further. Prescott's asking about his current albumin and complement. Cody, did you want to speak to those?
Yeah, I didn't write down the complement. So we don't have the complement or albumin levels from his initial diagnosis when his IgG level was so low in 2005. But at the time of admission in 2020, they were both normal.
And then we've got some questions about vaccine responses, lymphocyte subsets, comment that the degree of lymphopenia is concerning. So all of those things were on the mind of the team as well. So you'll be getting that data from Cody shortly. There's also some question of nephrosis. Let's see. Also some thoughts to think about complement deficiency. And I think that was actually the very first comment we got on this presentation as well. There's also a thought, could this be an ADA2 deficiency? Another thought, could he just be losing IgG? And Cody, I know we talked about a lot how this patient really could have multifactorial reasons for having hypogam. Would you mind speaking a little bit about what those might be?
Yeah, so throughout his, I guess when he initially presented and his IgG was 150 and with the GBS meningitis, you know, potentially a contributing factor could be nephritic syndrome with his lupus nephritis. And we don't really have a comprehensive laboratory data from that episode to comment on that, but that's a hypothesis. He was also on CellCept, which can cause hypogammaglobulinemia, so difficult to say, but possibly multifactorial. And one thing that's, I guess, frustrating is we don't have an IgG level from pre-transplant, so we don't really know what his baseline IgG level was.
And we can say at no point did he have colitis as part of his phenotype. So no thoughts for additional loss there, nor that as being another site of inflammation for this patient. All right, also a thought for a C1q deficiency. Let's see. Oh, we've got so many comments going. Was a CH50 done? Did you have pre-retux IgG subsets? We did not. And so Cody, let me go ahead and allow you to give the group the rest of the labs that they're anxious to see here.
Sure. So we did get vaccine titers. So his pneumococcal, tetanus, diphtheria, mumps, rubella, and varicella titers were adequate. His H flu and measles titers were below the protective threshold. And we did, this came a few months after this evaluation, but he was vaccinated for COVID-19 and we did test for SARS-CoV-2 spike antibodies and he had no detectable spike antibodies. We sent a B-cell memory test and observed that he had 97% naive B cells and negligible switched or unswitched memory cells. And this is his flow count from October of 2020. And we don't have, for reasons that are confusing to us, we don't have an absolute lymphocyte count or an absolute CD8 T cell count, but the numbers are all quite low. And I guess most concerning is the absolute CD4 count of 16. So I can pause again and ask how this changes the differential diagnosis and what people would want to do for this patient.
There is a question, Cody. Did he have HIV?
Negative HIV testing.
Yes, of course, always one of the first things we want to make sure of if we have a CD4 lymphopenia. He at no point had evidence of a protein losing enteropathy or colitis of any kind. And then in terms of the other cytopenias, we showed a little bit of data that he had actually had pancytopenia at one point in time. Let's see, we've got another thought for differential. Could this be GATA2? Another question, did we trend IgG levels? Yes, we did. And IgG levels most of the time would sort of hang out in the 500s to 600s. And then I think this level that we showed that was 300 and something was about the lowest he would typically go on his own, with the exception of that original level that was very low in the 100s years ago. Someone's mentioning long-term CAM path effects. Very important. You'll hear more about that coming up. Any history of any cytokine data, not that I'm aware of. Any history of EBV infection, not that we know of. Concerns for bone marrow failure. Possibly that's why they did the bone marrow biopsy whenever he was admitted and allergy got involved in his care. And unfortunately, the bone marrow biopsy was so non-specific. If you read sort of the full pathologist interpretation, they basically say like everything you could think of is still on the differential. So hard to know. And then there's someone else thinking, could this be hyper IgM syndrome? Wonderful. So Cody, what happened for this patient next?
Great, yeah. So he was started on subcutaneous immunoglobulin replacement in January of 2021 and ended up stopping after a year, really per patient preference. And he did get a dose of Evusheld in February when that became available, February of 2022, so a year after starting sub-Q Ig therapy. In December of 2022 is when I saw him in clinic. And at that time, he'd had no opportunistic infections, no recurrent common infections, no additional episodes of meningitis. His abscess had resolved. He did have COVID-19 infection, which was largely asymptomatic. We rechecked his immunoglobulins and his flow at that time. His IgG count had risen from 395 to 660, and his other immunoglobulins were still within normal limits. His CD4 count had risen from 16 to 120, and his CD8 count had normalized. At this point in time, we we're concerned, this is now 3 years out from his transplant, that we might be missing something. He has some persistent lymphocytopenia and the history of autoimmune disease. We decided to send the sequencing panel and found that he had a NOD2 R702W missense mutation, as well as a variant of unknown significance in the DDX41 gene, which doesn't fit our clinical picture. So any thoughts on the role of the NOD2 mutation versus the role of immune suppressive agents in this patient's course?
Maybe Kate will bring you in here really quickly. You've seen a lot of patients with NOD2 mutations and IBD and so forth. Do you think the NOD2 mutation is relevant here, either for the immune deficiency or the autoimmunity?
I mean, it's hard to say that it's completely irrelevant, but just the body of literature suggests that it's a relatively specific susceptibility to IBD. So it's not like itch. It's not like some genes where overall the risk of autoimmunity is increased and you could just sort of fold lupus into that bucket. So I think it's a bit of a stretch to think that the NOD2 is either causal for the lupus or even as a modulator for the hypogam, but never say never.
Right. And so what about immune suppression? I've seen some comments about rituximab. I've seen some comments about Campath. Do we still think those fit for what we're seeing with this patient this far out from transplant? I'm not seeing any comments. So either everyone is like, this is super obvious, yes, of course, or everyone is saying, no, absolutely not. Well, Cody, let's, so not rituximab with the CD4 lymphopenia, absolutely. Could this lupus itself cause the lymphopenia? And Terry Harville is mentioning it can take over 7 years for patients to recover with Campath. You know, Cody's going to talk a little bit about this, but that's sort of one striking lesson from this case is how very long it can take patients to really resolve after they have received these immune suppressive medications. So Cody, why don't you tell us a little bit about NOD2 mutations and then tell us a little bit about a few nuggets on the immune suppressives this patient received.
Yeah. So yeah, a bit about NOD mutations first. So the most severe manifestation of a NOD mutation that you all might be aware of is Blau syndrome. And typically this presents in early life with skin rash, arthritis, uveitis, and those mutations associated with that most severe phenotype tend to cluster in this NOD-NOCT domain, whereas mutations in other segments of the gene are commonly, particularly this LRR, leucine-rich repeat region at the end of the gene, are commonly associated with autoinflammatory diseases, particularly autoimmune colitis. We did find a cohort of NOD2 associated or attributed autoinflammatory diseases. And it is interesting that one of the patients that was included in that cohort did seem to have a phenotype that was similar to our patients. So that was a 56-year-old gentleman with the same arginine 702 tryptophan mutation who had fever, rash, arthritis, no infectious history, but did seem to have a mild hypogammaglobulinemia with an IgG of 600. And so, as Kate mentioned, there's very tenuous data linking NOD2 to lupus pathogenesis, but there is this proposal in a rheumatology journal that suggests that the ligand for NOD2 MDP, which is a component of peptidoglycan, could potentially enter cells, bind to NOD2, and set off pro-inflammatory signaling cascades such as NF-kappa B and IL-17, which could contribute to the pathogenesis of lupus. But again, it's not commonly associated with lupus. So now turning to the immune modulatory agents that he received. So the agent we'll spend the most time on, alemtuzumab, was used as an induction agent. And this agent targets CD52, which is a it's found on many leukocytes, including on both B and T lymphocytes. as well as NK cells, monocytes, and macrophages. And then in the setting of acute rejection, he received rituximab, anti-CD20, eculizumab, which is targets C5 and puts a hard stop on the complement cascade, and basiliximab, which targets CD25, which is the T cell IL-2 receptor. He also received a second dose of alemtuzumab during this phase of acute rejection. And he was on several maintenance medications, including belatacept, which is a CTLA-4 Fc fusion protein that blocks T cell co-stimulation, and mycophenolate, which everybody's familiar with, and prednisone at one point in time. So just a reminder about how these agents really function to cause cell depletion. And this is specifically for alemtuzumab, but most of the monoclonal antibodies function in a similar way. We're targeting binding of the antibody to the epitope of interest, in this case CD52, is the initial step. And so one mechanism of cell killing is antibody-dependent cellular cytotoxicity, where the Fc region of those antibodies is engaged by FcγR3 on CD8 cells, NK cells, and release of cytotoxic granules, which causes cellular destruction. There's also complement-dependent cytotoxicity, and actually just the cross-linking of those markers like CD52 can cause apoptosis of the target cell. And what's not known is, given all these agents that he received, what is the potential for synergistic effects of these different agents, or potentiation of these agents in combination. And then I'll touch briefly on the duration to immune reconstitution in the setting of alemtuzumab, which I think is an important question. We did find a review on this topic, which goes through how long these different immune cell subsets take to come back to pre-transplant levels following CAMPATH therapy. And the surprising thing for us was that B cells and CD8 T cells recover very rapidly, 6 to 12 months, which we saw in our patient. But CD4 T cells can take 2 to 4 years, or apparently up to 7 years, to recover fully. And so this suggested to us that perhaps this could be a normal timeline for CD4 population reconstitution in our transplant patient. All right, so a brief summary. We talked about an adult patient with lupus who received a renal transplant and was administered multiple immune suppressants, and who developed CD4 lymphocytopenia and hypogammaglobulinemia. His only infectious complication, interestingly, was this perinephric abscess, despite very minimal infection prevention measures. We discussed the fact that he has a NOD2 mutation, which is commonly involved or implicated in the pathogenesis of autoinflammatory diseases, including potentially, but it's not a firm tie to this patient's lupus. And lastly, that CD4 T cell populations can take up to 4 years to recover following the use of a potent induction agents such as alemtuzumab. And what's unknown, as we discussed, is any potential synergistic impact of co-administered biologic medications on the time course of immune constitution, particularly CD4 population recovery. And we'd be happy to take any more questions.
Then I'll highlight a few things that have been going through the chat. Interestingly, we've heard from a few providers, one who has a patient with NOD2 mutation in hypogam, and then another one who has T-cell lymphopenia, both CD4 and CD8 with a NOD2 mutation. So who knows, maybe there's more that we need to understand about this mutation. I feel like that's always the case with genetics. We never stop learning. And then Helena, one of the providers for this patient, commented about the likelihood that the cytopenias are all related to the lupus, essentially saying that this is a really muddy case. And I think, you know, that's sort of one of the take homes from here is the thought exercise and complexity of thinking about a patient with genetic mutations and underlying lupus as an autoimmune disease, and thinking about the fact that they've had all these immune suppressive agents. But his lupus actually has been very quiet for a number of years. And with that, Kate, would you share a few thoughts about this case?
I'll try. It is muddy, and Carolyn and Cody, I think that really is the point. This is just kind of the real life of it. But I wanted to come back to NOD2 because I think I perhaps did the question an injustice. So I had a vague recollection of this syndrome called Yao syndrome. And Yao syndrome is due to a mutation in one of the introns, but half of the patients had that in trans with the R702W variant. And Yao syndrome is they didn't report any lupus patients, but it's much more of a pleomorphic autoimmunity. So I do have to correct myself. There is one mutation that, at least in some cases with the variant that this patient had, can cause much more of a systemic autoimmune process.
Wonderful, thank you. And then we're getting a few more questions in here about whether this patient has had a CVID workup. We know that they responded well to most, but not all of their vaccines. We know they had the low switched memory B cells. And we know that there were no CVID associated genes on the genetic testing, with the exception of this NOD2, which I'd have to go back and look at the literature if that's one of the many genes that has been found in CVID patients. So, you know, could this be some CVID picture, or I can't remember the name of it, like the combined like CVID plus T-cell issue? I mean, it could be, again, the patient has lupus, they've received these immune suppressives. And then there's a comment about the patient needing prophylactic antibiotics for the low CD4 count. And I think that's something really interesting. You know, a lot of times as an allergist, you come into the case and, you know, it's already, the patient's had this sort of long history. And as we go back and look, the patient had their transplant, they were on a bunch of immune suppressive medications for 6 months. And then I would assume per protocol, they just took them off after 6 months. And the funny thing is, he's doing so well from an infection standpoint. How do you tell this person, oh, you need to go on these, you know, things to prevent you from having an infection? He didn't even want to continue on the immune globulin. It's ambiguous. I don't know. Kate, what would you do?
I mean, I think with careful watching, I think it's fine for him to come off. It does look like he's having a gradual recovery, but I think Tracy's comment about being mindful of the state of the patient. So Carolyn, your comment that this was muddy, there was a lot of immune suppression being poured into this guy that was having a lot of rejection. You have to be mindful of the state of the patient at that moment. And I think one of the roles that we often default on is our role in managing secondary immune deficiency. So Tracy, I love your comment that we should be involved in trying to help people think about how do you manage folks whose immune systems are, for whatever reason, less than perfect.
Oh, 100%. I mean, you have the endorsement of Kate, so mine doesn't matter, but 100%, I feel like that's an area where we really have a lot that we can offer as immunologists. And it's an area that I hope really grows and we can see grow as you know, the years go on here and we become a larger, more experienced field. And then Helena is just reminding us that he did receive a lot of rituximab, and that may be a big part of what's going on for his B cells. Yes, we should watch him really closely for the PTLD, absolutely. And then Steve, if you're still on, do you want to tell us really quickly what your thought is about this Delta 5 NEMO mutation?
There are somatic mutations in somatic and some germline mutations in NEMO that are, I believe, in exon 5 that would potentially be missed in some of this coverage that could be associated with a lot of inflammatory problems, and just might be something else to consider. It's attractive to think that this is all immune suppressant related, but as I recall, he had a group B strep infection, a group B strep meningitis before he got all of this stuff, and a persistent gram negative. And you just start to think about, you know, a gram positive, a gram negative, lots of inflammation, and NEMO is something that just comes to mind.
Yeah, absolutely. And that's one thing that's really a little bit bothersome about that history. When you look back, we know he was hypogam at the time, but how many hypogam patients have we all seen? And they don't get GBS meningitis. So that was something that was sort of striking. Absolutely. In terms of what minimum immune monitoring protocol I would suggest for a post-transplant patient, I'm not sure if I'm particularly qualified. I know a lot of this is protocolized, but I think you know, in general, I would echo the thought about being thoughtful as we might participate in care for these patients, you know, really trying to advocate for patients getting immunoglobulins and flow cytometry checked before they have all of this done, and then watching those whenever they actually go to remove the immune suppressive medications to see if you know, if they really ought to be removed, or if maybe a patient should stay on. And, you know, one thing Cody, our brilliant fellow, suggested as we were discussing these cases is maybe we need a little bit more research to really prove how much we should be doing. Or if there happen to be a lot of patients that just have these low T cell counts for some time and, you know, just do fine. So something that we should maybe know. I am loving the continued conversation in the chat, but we are running quite a bit over, and I want to be respectful of people's time. So thank you so much, everyone, for you know, all of this active participation. Thank you for all of our presenters, junior moderators, senior moderators. If there's anyone who is interested in presenting in the future, please email us. It's info@clin, CLIN, SOC.org, SOC.org. And please send us cases, and thank you so much to everyone. This was a really interesting learning session. Appreciate it.
Thank you all. Bye.